Okay, welcome again, class. This is a early Saturday morning. We've got group 10, and they're going to be reporting on the EMTALA. So we've got Brennan and Sire here. So I'll go ahead and turn the time on over to them. All right, guys, go ahead and take it away.
Okay. All right. So as Brother Gage said, this is the MTALA presentation. That's what I call it anyway, MTALA. Unfortunately, Tammy isn't here with us, but she would like to be here. So we'll just go ahead and present everything they prepared for that. Brother Gage, you do the next slide, if that's okay. So just a little bit about the EMTLA. So the basic premise of this legislation is that patient care should be impartial and equitable. Those are the main things. And regardless of either race, gender, creed, religion, or any financial status of the patients, they should still be given that care. And an important thing is if they are denied that treatment, that could put their health condition in jeopardy and even lead to their death in some cases. So that's why it's really important that they are stabilized in a timely manner. And we'll talk more about that as the presentation goes on. Next slide. So just a little bit of a brief history about it. Much of the events that led to the passing of the legislation originated in Cook County Hospital, Chicago. So in 1986 and 1987, there were two physicians that published an article detailing patient dumping. So basically what that is the denial of or limitation in the provision of medical services to a patient for economic reasons and the referral of that patient elsewhere. Just like simplified, if a patient goes to a hospital and they request to be seen and they are denied that because of any reasons that is discriminating, mostly because of their financial status, then that's patient dumping because they're transferred to another hospital because of that reason. And back then, the majority of such transfers were minorities and unemployed people. So that right there was discrimination in their eyes. And the reason that was given was because of in 87% of the cases was lack of insurance, and about 6% of them had only given written informed consent, which if you look at that, that's not even a lot of people at all. And the statistics of it were people that were transferred were twice as likely to die as those being treated at the hospital. And 24% of the patients were considered to have been transferred in an unstable condition, which is very dangerous for them in that regard. Okay, and next slide. And then it was concluded that this practice was done because of financial reasons, and if the care was delayed, then the patient's health would greatly be jeopardized. And what's interesting to note is that prior to this incident, there were actually already safeguards that were established. However, most private hospital practices weren't following them. So like as we learned earlier in the semester, the Joint Commission on Accreditation of Hospitals, they're the ones that approve, well, kind of like assess hospitals and make sure that they're doing what they're supposed to and they're good to go. They stated that individuals shall be accorded impartial access to treatment or accommodations that are available or medically indicated regardless of race, creed, sex, nationality, or sources of payment for care. So that's pretty similar to what the EMTLA is. And then next slide. So there was a legislation called the Hill-Burton Act, which pretty much says the same thing. It established federal guidelines for emergency medical care at certain hospitals, and many state laws were also on the books, mandating non-discriminatory access to emergency care. So since these bylaws were being ignored and weren't being followed, the emergence of the EMTLA legislation came about, and that's why it was promulgated and kind of necessary. And we will be talking about that in the next couple of slides. I think that's Brennan.
No, that's slide number 6.
6, never mind. Okay, my bad.
Okay.
So it was necessary because I think we've learned this earlier, there was the COBRA legislation, and it was supposed to kind of support that, which dealt with a lot of Medicare issues. So the law's initial intent was to ensure patient access to emergency medical care and to prevent the practice of patient dumping. And a lot of it was because of there were uninsured patients that were being transferred, and so they wanted it to, most of the private practice as well as public hospitals and every other hospitals, to be able to, one, stabilize the condition before transferring, or two, provide that care right there at that hospital, and have the people that can't afford it be able to get that regardless, because I mean it's healthcare and that's what they do. And then next slide. This one is what led to its promulgation, which pretty much means why was it promoted. So like we said earlier, because of the reports from Cook County Hospital as well as the bylaws that weren't being followed, there was the need for the EMTLA to be established. And what's cool about it is it's a little bit more stringent and stricter and more specific than the other bylaws, and that's why it's more effective in its enforcement. And we'll talk about its consequences also in a little bit. Okay. I think the next one's 8.
So what does it mandate? Essentially what EMTALA is a law created in order to help people who aren't necessarily able to pay for the initial medical bills so that they can receive proper treatment so they can continue to live. And so what does this mandate? Well, it mandates a medical health screening, first of all, so that way a process can be conducted in the first place. Secondly, all patients seeking care in an emergency department must be evaluated by a competent clinical professional. And if found having a condition requiring emergency care, must be treated until stabilized before any transfer. So like what Sire was saying before, how people were getting transferred beforehand, before this law, I mean, they were usually dying or suffering from some sort of handicap because they weren't getting treated on the spot. So this is one of the important parts why EMTALA law was created. Thirdly, for women in active labor, that's a huge thing. The hospital must deliver the baby unless the institution is not equipped to do so, which is understandable. You're not going to deliver a baby at a hospital if you don't have the instruments and the training to do so. The fourth point, the hospital to which a stabilized patient or one who must be transferred because the originating hospital does not have the necessary services or personnel is to be sent must agree to accept the patient. The patient must consent to the transfer if possible. Obviously, people who are unconscious can't consent, and there are things that go in and out of that to where you can or can't transfer them if they're unconscious. You'll understand in a second. Adequate medical records must accompany the transferred patient. Only makes sense. How are you going to treat a guy if you don't know what's going on? You need his records in order to see what's wrong with the patient in the first place. Next slide, please. So here's a little chart. This really breaks it down easy. So first you have the medical screening, then you can go up. If there's no medical emergency, then EMTALA ends. You're not going to get that free treatment, quote unquote. And then if you go down on the red part of the chart, it says yes, emergency medical situation. Then it bifurcates, and there are two options that go with that. You can either stabilize the person, and then that's where EMTALA ends essentially, or you appropriately transfer that patient to a different facility where they have better equipment or personnel or training, and so, excuse me, and so forth. Next slide, please. Okay, this is a very brief and easy list of things to do when a patient refuses care. So the first one is to ascertain adequate decisional capacity, assess the patient's values and application to the situation at hand, address the patient's concerns, inform the patient of the risks of refusal of care, involve other parties when appropriate, such as their family, a social worker, patient advocate, consider alternative treatments or treatment, provide appropriate care and follow-up information when possible, and avoid punitive statements and scare tactics. Document the informed refusal, discussion, and outcome, and consider telephone follow-up. These are all safety procedures that physicians and nurses will have to take if a patient refuses care in the first place, because as a medical professional, your first duty and responsibility is to take care of your patient. If you're not doing that, then you shouldn't be in the business. Essentially, these are the steps that you should be following as a medical professional, physician, nurse, whatever, in order to make sure that this patient that is refusing care is darn sure that they don't want the care. Next slide, please.
So what actually is in the actual legislation? So if we break it down, there are three main things that it says. Before we start that, actually, it says that there only facilities that participate in Medicare are included, but there are also about 98% of all U.S. hospitals are also under this policy or legislation. So the first thing, hospitals must perform a medical screening. So like Brandon said earlier, those are the steps that you need to take for the medical screening on any person in order to determine if there is an emergency medical condition. And second, if there is one, the hospital staff must either stabilize that condition or they can transfer the patient if the patient is healthy enough to be able to be transferred to another facility that is has more resources for that treatment. And then finally, hospitals with specialized capabilities like burn units or special maternity care are required to accept these transfer patients in need, as long as they have the capacity to treat them. And next slide. So while the investigation of violations are the responsibility of the Healthcare Finance Administration, the actual enforcement of the penalties and citations are the job of the Office of the Inspector General of the Department of Health and Human Services. That's a mouthful. And it is important to note that most physician malpractice policies will not cover those administrative penalties. So they actually have to pay, or they might have to pay out of their own pocket. So that's why you see a lot of physicians having special insurance for specifically for medical malpractice. For part of the reason that's why. And next slide.
All right, so what impacts does it pose on the healthcare industry? EMTALA has far-reaching implications for all aspects of emergency care of patients. Although unambiguous in its intent, it is inherently ambiguous in its interpretations and has as many unforeseen ramifications as there are limitless presentations of disease in the ED. One important consequence is monetary, so having to do with money. According to the American Hospital Association, in 1996, about 16% of ED patients were uninsured. The ED is the portal of entry for as many as 3 out of 4 uninsured patients admitted to the nation's hospitals. That's huge. Traditionally, uncompensated care was recouping by charging more for services for the insured. Though such cost-shifting hospitals were able to provide care for the indigent and stay financially solvent. However, prospective payment systems, diagnosis-related groups, and health maintenance organizations have hindered hospitals' abilities to continue this practice. The uncompensated costs to emergency physicians for services provided under EMTALA were estimated to be about $426 million in 1996, and the cost to hospitals for uncompensated inpatient care is a staggering $10 billion. Next slide, please. So what are the drawbacks? So this is a double-edged sword. Y'all know what that means. The good side is that patients with emergency conditions are being taken care of. They must have an evaluation exam and they have to be stabilized, which are two hugely important things when you're going to the hospital in the first place. That's where doctors can actually base their treatment off of. Once you're stabilized, then they can start really treating you and getting to the actual root of the problem. The negative side is that EMTALA is the largest unfunded mandate on providers that the government has ever instituted. So that seems very shaky. How can you trust that when you read something like that, that it's the largest unfunded mandate on providers that the government has ever instituted? That's just a huge risk. EMTALA also brings the threat of lawsuits. So this means it added another layer in that patients could now sue under this law. Now, if on one hand, a hospital is still dumping, as in taking those patients that aren't stabilized and then just dumping them to a different hospital, then it's appropriate to sue. But if a hospital discharges a patient to a nursing home and there are complications and the patient then sues under EMTALA. Make sense? Next slide, please. Okay, so I contacted the Idaho State Department of Health and Welfare via phone, and I also looked them up on their website and found out some things via the telephone conversation and also on the website about their role in EMTALA. So this is what I heard from them. Because Medicare and Medicaid requirements vary by provider type, we cover each provider or certified supplier separately. Any institution or facility that is regulated by federal COPs or requirements for participation in Medicare and Medicaid must adhere to those conditions or requirements and administer them in a manner that does not violate any individual's rights. So that goes along with the previous slide where we were talking about the drawbacks with the pros and cons of EMTALA, how there are no necessarily allowed dumping, therefore we can't be mistreated, quote unquote. We have to be stabilized first, and then we can go on to actually having to pay or having to have insurance to pay for us. Or we, well, that's what I was talking about in the last line of this slide, where it says it does not violate any individual's rights. We have a right to live. And the latest issue I found out about was the Ebola outbreak in 2014. It says the CMS released an SNC 1510, so a document, on November 21st, 2014 to provide guidance to hospitals and critical access hospitals regarding meeting EMTALA requirements in the case of individuals potentially exposed to Ebola. So that's an interesting thing because Ebola is an infection that it doesn't knock you unconscious necessarily. So people are going to present to the hospital or to a clinic or whatever you want to name up, and they're going to have these problems. And so this issue that EMTALA or that the CMS released was to address the issue of, should we take care of these people with an Ebola virus under EMTALA law? Would that be okay? And so far it is. They released that document, the SNC 1510, saying it was okay and that they are going to do it. Next slide, please. So we got a mini quiz going on. Here it is. Next slide, please. All right, take a good look at this EMTALA mini quiz. Since it's being recorded, pause it. Try not to look at the very end. The bottom right has the answer key. So cover that up with your hand or something, but look through these questions. And if you can answer these just by hearing what Sarah and I have presented, then you're pretty solid on understanding what EMTALA law is. So go ahead, pause it, and then you can go on to the next slide, please. This is what we used. These are our references. And that is EMTALA law.
Awesome. Very good. I love the quiz at the end. Good
Are we
job.
done recording now?
Not yet.
Okay.
We can be in just 1 second. So anything else you want to add before I let you go?
I don't have anything to add.
Okay. I will stop recording. Great job, you guys.
Thank you.